Here I will talk about management of gestational diabetes, recommendations, lifestyle, and insulin use, metformin, and telehealth. So lifestyle behavior changes is an essential component of management of the GDM. Insulin is the preferred medication for treating hyperglycemia and gestational diabetes mellitus. Metformin and glyburide should not be used as first-line agents, as both cross the placenta to the fetus. Other oral and non-insulin injectable glucose-lowering indications lack long-term safety data. So metformin, when used to treat polycystic ovary syndrome and induce ovulation, should be discontinued by the end of the first trimester. Telehealth visits for pregnancy women with gestational diabetes improve outcomes compared with the standard in-person care. GDM is characterized by increased risk of large for gestational age, birth weight, and neonatal and pregnancy complication, and increased risk of long-term maternal type 2 diabetes of offspring, abnormal glucose metabolism in childhood. This association with the maternal oral glucose tolerance test results are continuous with no clear inflection points. Offspring with exposure to untreated GDM have reduced insulin sensitivity and beta cell compensation, and are more likely to have impaired glucose tolerance in childhood. In other words, short-term and long-term risk increase with progression of maternal hyperglycemia. Although there is some heterogeneity and many randomized controlled trials suggest that risk of GDM may be reduced by diet, exercise, and lifestyle counseling, particularly when interventions are started during the first or early in the second trimester. There are no intervention trials in offspring of mothers with GDM. One important part of management is lifestyle behavior. After diagnosis, treatment starts with medical nutritionist and physical activity. Medical nutritional therapy and physical activity and weight management depending on pre-gestational weight, on pre-existing type 2 diabetes, as well as glucose monitoring, aiming for targets recommended by the 5th International Workshop Conference on Gestational Diabetes mellitus. So fasting glucose less than 95 milligram per deciliter, and either 1 hour postprandial glucose less than 140, 2 hours postprandial glucose less than 120 milligram per deciliter. Glycemic targets lower the limit of limits defines about for pre-existing diabetes supply for GDM that is treated with insulin. Depending on the population, studies suggest that 70 to 85% of women diagnosed with GDM under Carpenter's custom can control GDM with lifestyle modification alone. It's anticipated that this proportion will be even higher if the lower International Association of Diabetes and Pregnancy Study groups diagnostic thresholds are used. So medical nutritional therapy for GDM is individualized nutritional plan developed between the woman and registered nutritionist familiar with management of GDM. Physical activity, systemic review demonstrates improvements in glucose control and reduction in need starts to insulin or insulin dose requirements with an exercise intervention. There was heterogeneity in the types of effective exercise, aerobic resistant or both, and during the duration of exercise, 20 to 50 minutes per day, 2 to 7 days per week, or of moderate intensity. Pharmacological therapy for GDM with lifestyle and insulin has been demonstrated to improve prenatal outcomes in 2 large randomized studies as summarized in the US Preventive Services Task Force review. Insulin is the first line agent recommended for treatment of GDM. In the United States, while individual randomized controlled trials support limited efficacy of metformin and glyceride in reduction the glucose level for the treatment of GDM. These agents are not recommended as a first line, as we know, for treatment for GDM because they are known to cross the placenta, and data on long-term severity of offspring is of some concern. Furthermore, glyceride and metformin failed to provide adequate glycemic control and separated RCTs in 23% and 25 to 28% of women with GDM, respectively. Sulfonylurea are known to cross the placenta, so better not to use. Glyceride is associated with a higher rate of neonatal glycemia and macrosomia than insulin or metformin in a 2015 meta-analysis and systemic review. More recently, glyceride failed to be found non-inferior to insulin based on composite outcome for neonatal hypoglycemia, macrosomia, and hyperbilirubinemia. Long-term severity data for offspring exposed to glyceride are not available. So what about metformin use in pregnancy? Metformin was associated with the lower risk of neonatal hypoglycemia and less maternal weight gain than insulin systemic review. However, metformin radially across the placenta, resulting in umbilical cord blood levels of metformin as higher than simultaneously maternal levels. In the metformin in GDM, the offspring follow-up, MIG-24 studies analyze of 7 to 9 years old offspring. The 9 years old offspring exposed to metformin in the Akuland cohort for the treatment of GDM were heavier and had a higher waist to high ratio, waist to height ratio and waist circumference than those exposed to insulin. So this was not found in the Adelaide cohort. In 2 randomized controlled trials of metformin use in pregnancy for polycystic ovary syndrome, follow-up of 4-year-old offspring demonstrate higher BMI and increased obesity in the offspring exposed to metformin. So a follow-up study at 5 to 10 years showed that the offspring had higher BMI, weight to height ratio, waist circumference, and borderline increase in the fat mass. Metformin is being studied in 2 ongoing trials in type 2 diabetes, metformin in women with type 2 diabetes pregnancy trial, and medical optimization of management of type 2 diabetes complicating pregnancy. But long-term offspring data will not be available for some time. A recent meta-analysis conclude that the metformin in exposure results in smaller neonates with acceleration of postnatal growth, resulting in higher BMI in childhood. So the randomized double-blind controlled trials comparing metformin with the other therapies for ovulation induction in women with polycystic ovary syndrome have not demonstrated benefits in preventing spontaneous abortion or GDM, and there is no evidence-based need to continue metformin in such patients. There are some women with GDM requiring medical therapy who due to cost, language barriers, comprehensions, and or cultural influences may not be able to use insulin safely or effectively in pregnancy. Oral agents may be an alternative in these women after a discussion of the non-risk and need for more long-term safety data and in offspring. However, due to potential for growth restriction or acidosis in the setting of placental insufficiency, metformin should not be used in women with hypertension or preeclampsia or at risk of intrauterine growth restrictions. What about insulin? Insulin use should follow the guidelines. Both multiple daily insulin injections and continuous subcutaneous insulin infusions are reasonable delivery strategies, and neither has been shown to be superior to the other during pregnancy.